Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. This podcast is the third in a series of 3 on bloodstream infections, recorded from a live symposium. In this episode, we discuss how to integrate rapid phenotypic testing into clinical practice. We'll also hear learner questions from the symposium, all answered by our 3 faculty. Dr. Jasmine Marcellin from University of Nebraska, Dr. Jose Alexander from Advent Health in Orlando, Florida, and Dr. Michael Veve from Eugene Applebaum College of Pharmacy and Health Science at Wayne State University. To listen to the other episodes or to follow along with the slides, visit the show notes. Now let's get started.
Good morning. My name's Veve. I'm a ID pharmacist at Henry Ford Health in Detroit and Wayne State University's College of Pharmacy. So I'm going to talk a little bit about the implementation side and considerations. So, I wanted to start with, I don't think this is a test for every hospital, depending on where your practice site is. So, it's not for everyone, but there really is an opportunity for the right site. And a lot of that's going to be contingent on laboratory capacity and stewardship personnel to make sure that a rapid phenotypic AST is the right move for you. And then on the other hand, it's challenging to identify the right patients and organisms to treat. And you really have to dive into your local epi and potential practice barriers to identify the right person, the right patient, and the right organisms to apply rapid phenotypic testing. So I'm going to touch on this slide a little bit, but these are considerations for adapting, really, I would say, any rapid diagnostic test at your hospital or health system, but trying to spin it towards the rapid pheno AST platform. So first thing could be the stewardship team, the micro team, and infectious diseases physician colleagues perform a gap analysis. So thinking about performance, the current landscape of performance at your health system, and maybe what are some of the goals that the C-suite has, or there's other directions for the stewardship team? And that can lead to some positive discussion about what work and who to test. Combine that with some of the local epi data, look at your antibiogram, look at the frequency of organisms, particularly maybe some of those that we don't have reliable genotypic markers from some of the bloodstream infection PCR testing. And communication, how are you going to do? You can adapt rapid diagnostic tests, but if you don't have a good platform of communication or pathways, generally you're not going to see that return on investment or value for patient care, and in this case, timely, appropriate antimicrobial therapy. Other lab considerations, is this going to be a 24/7, 365 approach, or is it batched? What about your stewardship personnel? How frequently are they working? Is there consistent stewardship coverage for the 24 hours, or, does third shift kind of get left off there? And then education, right? Like, who's the end user for this test, right? And I'm just thinking at my hospital, really think it's going to be hospitalists and intensivists who are primarily going to be seeing this, and a bunch of medical residence fellows and different clinical pharmacists. How do we educate them, and how do we identify this in the electronic health record so that these results are actionable? And then last but not least is kind of the quality assurance process. And I'm a big believer in, if you implement something, you really need to evaluate it to justify kind of the implementation process. So these 6 things are some significant considerations for rapid pheno. But I wanted to take it a step further, and you're like, all right, what is this guy talking about? And I want to use a case example of hospital and site-specific considerations, and I want to showcase how at my site we've done the same thing. So for hospital consideration, what's the landscape? What does that look like for you? What do you have available? And where's that added value for rapid phenotypic test? How's that going to look like? Talking about the stewardship program and microbiology lab capacity and space and some of those workflow limitations. And then location-specific considerations. Do you care for a large population where timely antimicrobial or antibiotic therapy is most likely to see a benefit? And I think the literature-based approach would be critically ill patients in septic shock, right? We know that that's where time really matters most over the grand scheme of patients with infections. What about immunocompromised populations, solid organ transplant recipients, and maybe some other immunocompromised folks where the prevalence of resistant organisms may be a little bit more common? And then taking a step back and looking at challenging gram-negative bacteria at your site. How often do we see these from blood? Are they typically resistant? What's kind of like the resistance patterns there look like for your site? And how common do we think these tests would be useful within those populations? So I'm going to fill in the blanks here. And, my health system, Henry Ford in Detroit. So some of the existing diagnostic tests we have an MRSA nares. We use a genotypic blood culture identification. We have some respiratory and meningitis and syphilitis panels and urine antigen testing, but we don't have an existing pheno. And how do we show value given the landscape of rapid diagnostic tests can be a challenge? I think we have an excellent infrastructure, but I'm biased. But there are still some concerns about how these results get reported to frontline clinicians and how are they interpreted from or distinguished from genotypic testing. And populations likely to benefit, we have a lot. We have a high acuity illness. We're a large hospital and health system in an urban metropolitan area. We see everything. We see a lot of those populations that have those resistant infections where they're likely to benefit. And when we're thinking of how could we best utilize, and I think back to some of Jose's slides, is what about these organisms where our genotypic diagnostic tests just don't reliably identify common resistance mechanisms? And to us, we thought of Pseudomonas aeruginosa, Acinetobacter baumannii, and Stenotrophomonas maltophilia, and evaluating these in bloodstream and trying to identify opportunities to escalate therapy and get patients on more active therapy sooner in their disease, their hospitalization. We also looked at the prevalence of these organisms. So in a year's worth, we have a lot of Pseudomonas, so 153 bloodstream isolates for individuals, and then less for Acinetobacter and Steno, but we know that those are commonly resistant organisms where timely antibiotic therapy can be a little bit more challenging. Okay, so it's great. We know that these pheno tests identify susceptibilities much faster and can get patients on active therapy, but that's all great. If you don't do the proper implementation steps, I think it sets your health system up for failure. So without significant planning with the lab, with ID consultants, with key stakeholders, and really the stewardship team, you might not see a benefit. So really, really important slide, in my opinion, is getting all that key stakeholder advice and really planning this out and planning to evaluate to show that return on investment is also a key component. I've talked about this a little bit more, but the incremental difference in turnaround time, like the bar just keeps getting narrower and narrower. So how can you justify using a test like this, and what kind of outcomes are you expecting? Successful implementation relies on a really robust practice model just as much as the technology itself, I think, and some of the automation in the microbiology lab, routing the phenotypic AST alerts within existing workflow is really essential, in my opinion. Timing of the results in the electronic health record. I know some of you might not be familiar, but some of these susceptibility results will result at different times. And then I also wanted to plug utilization of microbiology nudges, of course, because I think that's also an efficient way to get clinicians to prescribe the right antibiotic therapy without necessarily having stewardship personnel responding to it. So big nudge fan. So this is kind of a snapshot of how this works for we're in process of implementing a similar workflow. Rapid tests are used only for Pseudomonas, Acinetobacter, and Stenotrophomonas maltophilia in ICU populations. And you can see on the right-hand side, patients with a bloodstream infection, if it's a positive, they get flexed to a genotypic AST platform. That gets routed to the ID pharmacists and is resulted in the electronic health record, while conventional AST is still being performed. And kind of where we're trying to pivot the phenotypic AST is of those select organisms that we've talked about, adding that on is going to show some benefit just because of the limitations to existing genotypic platforms. The key here is we try to make these results actionable and route them to stewardship personnel who are routinely making recommendations to escalate or stop therapies. How many of you guys are familiar with ID pharmacist workflow at a hospital setting? Some of you who are pharmacists probably, or some of you I think have the wherewithal to ask some of these questions. But I actually on Friday had a session with one of our ID fellows and oriented him to our stewardship workflow. And he was like, whoa, I had no idea that this is what you guys do. And I think this is an important slide because if you're considering adapting some of these tests or one of these tests, it's really important to touch base with your pharmacist and talk about existing workflow and resources. So I'm an Epic hospital, and kind of our workflow here, we use the Bugsy module, and you can see on the left-hand side that figure there, we have a cascade of different results that the stewardship pharmacists go through. 200 unreviewed results makes me a little bit stressed right now standing up here. But on the right-hand side, you can see that box there, AMS BPA or best practice advisory, our practice advisory. And that's where all of our genotypic results and eventually our phenotypic results will get routed as a priority for the ID pharmacist to review it. And the way that this works is we have dedicated IT personnel who can create these alerts for us and route them to us to make this an actionable intervention, really, right? Otherwise, it kind of gets blasted into the void. So the summary in this slide is, do you know your stewardship pharmacist workflow? Or maybe it's not a pharmacist who's routinely doing stewardship at your site. Does this fit into it? Do you have IT support? And what are some alternative approaches in the event that you don't have this robust platform? I wanted to do a patient case example. So here's a 70-year-old patient admitted to the ICU with shock. Blood cultures are growing, gram-negative bacilli, and he was started on vancomycin, vancomycin, and cefepime. The organism is identified as Pseudomonas aeruginosa, and from the genotypic results, that gets flexed to the rapid phenotypic results that are then routed to the antimicrobial stewardship pharmacist. And look at that. We see that this isolate is resistant to cefepime and ciprofloxacin, intermediate to meropenem, piperacillin, tazobactam, and then susceptible to ceftolozane, tazobactam, and tobramycin, for example. And really what this would do is significantly increase the time to appropriate therapy in someone who's critically ill, who we know this is kind of the most vulnerable population in terms of timely antibiotic therapy. So in this case, the patient would get started on ceftolozane, tazobactam much more timely than conventional methods. Education is also really important, and generally the stewardship team is responsible for dissemination. And I just wanted to emphasize this is particularly important depending on how you use the test. Are the end users, and in my my case, the intensivist, are they going to be familiar with what the test is and how to respond to it, right? And that's on us to educate that. Formal evaluation of the workflow and opportunities. Anybody who's implemented anything in a hospital knows how challenging that could be. And I think the stewardship teams need to be really cognizant of that. And are there any changes that need to be tweaked or modified in order to get the best results? So, I'm excited about this technology. There's a lot of future opportunities, and, the application, a lot of the applications focus on gram-negative bloodstream infections, but what about other organisms where timely identification of susceptibility can be really important? And that's slow-growing mycobacteria. Those are always really, really challenging cases. Different Candida species. The challenge with using fast AST or phenotypic AST in these populations is the significant laboratory validation time suck that it is to validate these platforms in other organisms or other disease states, such as urine sources, respiratory sources, bone and joint, and gastrointestinal. And then I'm also interested in some of those other less common populations. So solid organ transplant and urosepsis with bacteremia is also very interesting to me to try to facilitate that early oral switch that Jose had kind of talked about. So takeaways are, you got to consider if this is the right fit for you. It's not the right test for everyone, and the decision should be institutional specific. Look at your organism prevalence, and then really look at workflow opportunities and capacity for the lab and stewardship teams. If you don't have a good understanding of the workflow, and if there's not someone actively responding to alerts, generally you're not going to see what you had intended. So that's a really key component of embedding that into stewardship workflow. Excellent. And thanks for your time today. I hope you found that informational.
Okay. Thanks, everyone. Appreciate your interest. And we've been having a lot of questions coming in. And so I'm just going to jump into it. we started off, and pretty much throughout this entire discussion, we've been using cases that are inpatient-based cases. And one of the questions that came in, either of you could kind of touch on, would be, what is the possibilities of use of rapid AST, phenotypic AST in the outpatient setting to help primary care clinicians kind of make better decisions about those antibiotics for UTIs, et cetera?
Ooh, I'll take that. So I do a little bit of outpatient stewardship, and I agree, commenter, that is a really great opportunity to expand in the ambulatory setting where it just takes a lot of time to get some of those results. I do think that there's an opportunity, particularly with maybe urinary tract infections, or probably one of the more common disease states where we would get cultures. The challenge, and I look forward to hopefully figuring this out, is validating phenotypic tests on urine cultures, really. I think that's kind of the developing a platform where you can reliably use the pheno in patients with urinary tract infections to get them on more active therapy faster would be a good future direction. We need some time to kind of figure that out a little bit more.
What about if your institution already has an antibiogram that they use to help with making empiric decisions about antibiotics? How does the rapid pheno play a role in, how does it help to augment the antibiogram, or is the implementation of rapid pheno for institutions that don't use an antibiogram for those sort of decision making? I was looking at Jose when I
okay. So the antibiogram is a tool that we use for guiding empirical treatment. So we have cumulative data. We evaluate the patient from the perspective of multi-drug resistant risk for that patient and decide what is the best approach based on the population. And if we know the organism, we have a very narrow point in the antibiogram. The advantage of having a rapid AST is actually can overpass the need for the antibiogram for that particular case. You already have a susceptibility profile specific for that patient. And now you have not only the clinical component, but now you have a whole organism antimicrobial profile that will allow you to optimize the initial implementation of empirical treatment that was based on the antibiogram. So we still need the antibiogram because it's going to be that will be the driver for that initial treatment. But the rapid AST, the advantage is that optimization can be done faster and sooner, specifically in a case-by-case scenario.
Okay, so it's meant to help, not
complex.
Yeah, only thing I would add is if you practice at a site that does not see gram-negative resistance at all, then I don't know if you're really going to see that additional value outside of using some traditional stewardship antibiogram services where you could try to facilitate that early switch in the same capacity. You're just not going to have the susceptibility results. But that just might not be, depending on where you're at geographically, that might be the case.
I just want to add also, for the perspective of rapid AST, there is a lot of discussion. We should limit this to specific units in the hospital, right? Maybe ICU. And the test is the power that we can take, the benefit that we can take for this test is based on the action that we want to take. A lot of patients ICU, critical care patient with high risk. If the patient is severely compromised, and you tell the clinician, oh, this is just a pan-susceptible E. coli, they just go from meropenem to, ampicillin sulbactam. There is a fear factor that is not going to allow many of those patients to be de-escalated. So that is another component to have in consideration. What is the clinical condition? Even if you have evidence that the organism is pan-susceptible, is that we're going to be able to break through that fear factor to keep patient in broad spectrum a little bit longer, even when we have evidence.
That's a good point.
So then what's the answer? How do you help? Because we're going to give folks more tests, more opportunities to get that data. But what I'm hearing from you is ultimately we may still be in a situation where we might continue broad spectrum antibiotics unnecessarily, more to treat ourselves than the patient. And so what's the solution to that?
So, there is the clinical judgment that play a big role. And I don't know if we have a solution to be able to change. We can provide evidence, education, material, data that support that the escalation is appropriate. But it's this fear factor. I remember the case that, or MRSA MSSA BCID is pretty accurate. And we have one case that we mixed the gene, and that created a whole change from the perspective of some of our providers, that they didn't want to trust the test anymore just for one case. So what we proved that was probably less than 0.1% of the scenario. So I think that the clinical judgment played a big role. And I think part of the education and conversation with data is to be able to make sure that they continue using clinical judgment, but the clinical judgment can change the outcome of what is normally used for them.
Okay, thank you. I'm going to switch gears to another question, but before I do that, there is someone out here who asked the question, are there any bug-drug combinations on your panel where you have no claim? And if you can, whoever wrote that question, if you can clarify just a little bit more, I think you're asking an interesting question, but I just want to make sure I can ask it in the way that's going to get your answer. So just type it into the, thank you, appreciate it. While you're doing that, I will move to a question about breakpoints. So what breakpoints are the phenotypic results based on for these tests?
So they are based on FDA breakpoints, and every manufacturer, it's important to check with the manufacturer and the packet insert and the recommendation of the manufacturer. But all these platforms come with FDA breakpoints. We are used to have automated AST platform that we can validate new breakpoint, CLSI breakpoint, make changes user. So I think those are some limitations that some of these platforms have. Hopefully in the future, laboratories we can have more open access to this type of software that we can validate ourselves. And I think could be a limitation, and it's important for you to have that in consideration. In regard to the drug-cost mismatch, comments about that is, there is limitation of the platform and performance, but they also gap in regard of the FDA indication for certain drugs. So if there is no FDA indication for a specific drug block combination or source, it's possible that many of these rapid AST are not going to give you that result. It's not that the instrument have any limitation technical, is that there is a limitation in regard of the indication for that particular drug. Could be another gap, some drug with bug mismatch that there is indication and the instrument doesn't give you that information, because could be some limitation of the performance. So that in that two different aspects, it's important to have a well-described or discussed with the manufacturer when you decide what platform fit for you.
Does that answer your question? Perfect. Okay, so at the MAD ID meeting in May, so there was a presentation about using rapid diagnostics with no beta-lactamase enzymes detected, but approximately 20% of the E. coli was resistant to ceftriaxone from different mechanisms. So what the question is, what is the benefit of rapid phenotypic AST in patients with E. coli in that situation? Either of you, Michael, you want to?
So that is the perfect scenario for this type of technology. So we know that the epidemiology can be set with certain organisms. CTXM is the most global ESBL. Resistant to ceftriaxone is ESBL of AMC or carbapenemase. Some of them are already, or most of them can be identified by genetic profile. But when you have a resistance to a specific class that is caused by a gene that is low prevalence or no presence in any other rapid PCR, the final result for that type of cases is to have a full phenotypic profile. So that is the perfect scenario. If you have a high prevalence of ESBL that are no CTXM, this is the perfect scenario. If you're seeing a lot of AMC and E. coli Klebsiella, this is the perfect scenario because we know that we don't have AMC markers. And if you're seeing a lot of carbapenemase, non-carbapenemase producing Enterobacterales, this is probably the best technology because you're getting the final AST rapid, faster, and it's not based on resistant mechanism. It's based on the summation of all those mechanisms together, how they reflect in the phenotypic profiles.
Okay. Question about just the implementation of the rapid AST. Are you aware of any data that just kind of tells us how widely this is implemented across the country, and like how many hospitals are using this currently?
Good question. I don't know. I think I'm not aware of survey data specifically to phenotypic platforms. I don't know, Jose, if you know any of those data, but I do think that's a need to get a better idea of who's using what in which areas as a future research direction. I know there's more, obviously genotypic testing has been around for longer, so there's still a gap there.
I think the experience is mostly with LDT applications.
Mm-hmm.
So now we have some FDA approval method that is right now getting deployed through clinical settings. The experience that could be around is probably some LDT modification of other platforms.
Sounds like a really cool fellows project or ID pharmacy residence project. What do y'all think? Okay, we maybe have time for one or two more questions. One? Okay. All right, let's make it good. Okay, so here's a question that, I just want your thoughts on this. I mean, we may not have a solution to it, but, earlier we were talking about ways that there's the differences from a global standpoint in antimicrobial resistance and implementing things in resource limited settings. And so if we think about global resource limited settings where the rates are higher, as well as in the United States in rural resource limited settings, what are some of the ways that clinicians in this room can help to address this with the rapid AST in resource limited settings?
Ooh, that's like the Willy Wonka golden ticket. I wish I had an answer to that. I do think that it's a clear challenge. I think
Access to the testing, I think, is step one in trying to promote an access to these low middle income countries and other more rural countries and show justification of benefit within that population. I think we need more, we need funding to support this work. I think we need access to these tests and showcase how, I think, Jasmine, to your point, you'd see larger incremental value in implementing these tests in those specific sites. And I think we need more data to showcase that.
Thank you. Also a call to action, I suppose, for
Yes.
people with money to help us to address this issue.
Well, thank you to our faculty and many thanks to you, our listeners. To listen to the other two parts of this podcast or to download the accompanying slides, click on the link in the show notes. Thanks so much, and we'll see you on the next podcast soon.